Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
I cannot wait to dive back into part 3 of this insanely useful guide to SIFO. So when we left off, we talked about some of the broad spectrum herbs that we use. Let's just dive right back in and let's keep going with herbs.
Okay, so we talked about neem, coptis, noni, olive leaf, and there's a few more we wanted to mention. We mentioned candistat, which is a blend, and then Candiclear 4, or now called Clear 4. Both of you have had significant
So
success
this is
with.
my favorite SIFO packet. It's like a tablet and 3 capsules. The tablet and the 2 middle capsules, it's like a little strip. The tablet and the 2 middle capsules are antimicrobial, and the last capsule is a probiotic. It's got allicin, caprylic acid, cinnamon,
And
probiotics, yeah. And
Okay.
the way I dose it is if I can have them take the tablet with breakfast, the 2 middle capsules with lunch, and the probiotic with dinner, that's awesome. If not, then they take the tablet and the 2 middle capsules or the antimicrobials with breakfast, the probiotic away from it. But I feel like when Clear 4 goes on back order, I get in trouble. And I've tried to piece it together with other products, and it never works as well as Clear 4.
And it's also very easy for patients.
Yeah.
Right.
The
It's
compliance is
prepackaged.
high.
And then oil of oregano, which again for me falls into that same category of it's very broad spectrum, it's very strong. My mentors didn't like using it. They thought it was causing worse degradation of the microbiome than a lot of the other botanicals we've used. But I know a lot of my colleagues and you may also find it helpful.
It is one of those ones that I try, or oil of oregano is usually in my rotation because it's so broad spectrum. And so I use it. What do you think?
I just find a lot of my patients don't tolerate it well. It causes heartburn, it causes abdominal pain, and the taste is so strong. People just won't take it.
Is it brand dependent? Like, do some manufacturers make better products?
I think there are some that are more enteric coated, which probably helps, but a lot of them, just opening the bottle can, especially if you're taking it day after day for, weeks on end.
Right. Okay. So
then the other one that I feel like we also disagree on, which is what I only like to talk about disagreements when we're recording, because I feel like that's where like the meat of this podcast is. The other one that we disagree on is allicin, or in particular Alimed or Alimax.
Right.
I find Alimed, that's my go-to product. I actually say that Alimed is the equivalent of liquid gold. The liquid I give to my kids, I give to my grandparents. It's extremely effective across the board. I use it a lot with fungus.
So I'm confused about that because I have a lot of people who have methane, and then I have to go and treat SIFO after. And I already gave them the Alimed, and now I'm still dealing with the SIFO. So do you think it just wasn't long enough, or?
I think that methane is a bitch.
Yeah.
That's really what I think. I think methane's a bitch and it's hard to treat. And so I think sometimes you just need to go and
but
go.
But even if I've eradicated the methane and now I'm considering SIFO because they're still having bloating or intolerance to, sugary foods, things like that, why didn't the Alimed treat that?
In my experience, this is how I view it. I view it that with the methanogens, with the archaea taking up space in the GI tract, there is such a shunt of the microbiome that it's not a surprise to me that even when you eradicate the methane, there's still some overgrowth, and often that's fungal, and that fungus is probably more resistant because you've been using a lot of different natural agents. Yep. That's how I think
and
about it.
Can you talk about, because that company has 3 products that look the same to me except for dosing. Can you tell us a little bit about that?
So there's the capsule, which is 450 milligrams.
It's the professional strength. So there's Alimax, Alimed, and then the tincture.
Okay.
Right?
Yeah, I don't like Alimax. I think Alimax is like 40 milligrams
Yeah, it's a lower
per,
dose.
and Alimed is 450 milligrams per
Right.
capsule.
Okay.
The tincture does not taste like garlic at all because there's no sulfur compounds in it. It is literally just active constituent garlic.
Mhm.
And the tincture is 5 drops is 450 milligrams ish.
Okay. So you generally are using Alimed or the drops.
I'm using Alimed or the drops.
Okay. So that's something to experiment with.
Any
All right.
other botanicals that need to be on our to-do list? I mean, Pau de Arco, Pau de
Right.
Arco, I don't use it much.
I've had a couple of patients come in on it, and when they get off of it, they have reported that their symptoms have come back, but I haven't prescribed it.
Yeah, and then Mastigum is another one.
I
Again,
just don't like using gums that often,
Yeah.
but
yeah, I don't
I've used
use
that
it.
for H. pylori a little
I've
bit.
used it for H. pylori some too, yeah.
Yeah, and I've never tried just cinnamon. I know it's in Clear 4, but I've never given that.
Yeah, I use that
Same
more
thing.
for like blood sugar.
Right.
Okay.
I'm curious how you decide.
So I typically will start with SF722 or microregion. Yeah.
How do you decide between pharmaceuticals?
Oh,
and
gotcha.
Mm.
So that has something to do with with personal preference and bias. I don't love the idea of using antifungal prescriptions on a broad scale
Right.
if we're all going to be doing this. And so I typically almost always start with botanicals unless someone is opposed to it, or if they have mast cell activation syndrome, histamine issues, sometimes they don't tolerate any of the botanicals. So those might be those are some reasons where I sometimes will use prescriptions first. I will sometimes start with nystatin if I feel like it's hard to explain when exactly. I think it's if they've tried a lot of different things in the past and we still just aren't sure what we're treating. And we're trying to get an answer about, is this a fungal issue or some other sort of overgrowth or organism? But if I can choose, I almost always will start with an herbal.
And do you ever do both?
I have not tried combining both.
I combine both a lot.
Okay.
I combine both a lot.
Yeah, it's worth talking about. I mean, with SIBO, we know that there's combination regimens that seem to work better than individual ones.
I also just want to give a shout out about the Gymnema research. Do you guys know about this?
So
No.
we've talked about
Yes.
this
We've talked about
before.
it.
I haven't seen it work clinically, and I've had a number of patients who can't tolerate Gymnema.
Huh. Okay, let me just back up and explain. There was an in vitro study, in vitro, not in vivo, so in a test tube, and it found that giving Gymnema prevents the fungus from budding, prevents the hyphae from budding, right? So, that's how yeast grow, is they turn into hyphae, they bud, then it goes again and again. And so there are some in vitro studies that say Gymnema prevents the hyphae from budding, and so you can like stunt its growth while you're giving the antimicrobials. Not in vivo, in vitro, but pretty damn interesting. Gymnema is an herb that we use a lot for blood sugar regulation. I think that oftentimes when people have fungal overgrowths, they are carb searching.
Yeah.
Because carbs, A, are delicious, and B, they feed the fungus very, very quickly. And so Gymnema has the potential to help with that. It is another thing, but it's one of those things that I kind of have been convinced about, because I think Mark Davis is a phenomenal doctor, and he uses it and he says that's like he notices a big difference in his population.
Wow.
So
Interesting. I will say, getting back to Rebecca's question about combining them, I do sometimes combine the non-fungal specific herbs like we do with SIBO. So neem and coptis, I do frequently use those together. So I'll usually do either the SF722, the microregion, or I would say my third go-to is the Golden Thread Supreme plus Malia Supreme, are the ones I use most frequently.
okay, but you're not combining nystatin plus herbs.
I'm not, actually.
Okay. Are you?
Mm-hmm. Yeah, almost always. Or nystatin for about a month, if there are drug interactions I'm concerned about,
Right.
Sort of as a test.
Yeah.
And then I'll start a longer, usually Clear 4 with some sort of pharmaceutical with it.
That makes sense.
Sometimes people respond just to Clear 4. I mean, it is so
I love Clear 4.
good.
Right.
Sometimes people need like 2 rounds of it, but if it's really bad and people are just really fed up, then maybe we'll discuss adding in a pharmaceutical.
I will say I will often go, sometimes I'll start Clear 4 1 to 3 months.
Yeah.
There are people that I have it on for 6, 9 months.
Wow.
I mean, fungus is like,
It's hard.
it's hard, it's tenacious, and the whole point of it is to digest you.
Yeah.
Like, you kind of have to be a little bit more persistent, and herbs are not going out and like dropping bombs on it,
Yeah.
in my experience.
It's true. I think the other part of it depends how comprehensive we're being. So if we know from the start what we're dealing with,
Right.
as opposed to the patient who you're treating for 6 to 9 months, is it even still just fungus? Is there a protozoa that we
Right.
missed? Is there something else that these herbs are sort of treating but not eradicating? Because we're never going to fully eradicate yeast. We just want to bring it back to balance. So if someone's having symptoms every time we stop, we'll talk about that, but that could be more of the hypersensitivity issue.
Right.
So if we're doing everything together, I generally haven't needed to use antifungal herbs for years and years. But if we choose not to explore those other areas for very valid reasons, then sometimes that's the only thing that helps someone's symptoms stay at bay. So
Yeah, totally. Okay, so what else? Anything else that we're missing as far as herbals go?
Well, how do you pick which herbs you give? I mean, I know the two categories of the broader spectrum
Yeah.
are more specific, but how are you deciding what to start with?
So it's just kind of, I'll think about, do they want a liquid? Do they want capsules?
Got it.
How many capsules a day will this person be
Yeah.
willing to take? So there's not a great way outside of what has worked for my patient population is what I go to most frequently.
And how do you ever get efficacy with just like one round of the herbs, or are you usually doing rotating and
So I'll
multiples?
do one bottle of each and then
Okay.
say, let's talk when I'll say if it's helping and it's going to be a while before we meet again,
Yep.
get one more bottle of each. If
Right.
they haven't done anything after one bottle, I don't keep going with that
Right.
specific treatment.
Right.
I have had patients that miraculously improve with one round of treatment. I would say our patients usually have so many things going on. That's not usually that common these days, but I have had patients in the past, when we started, where we'd get more sort of patients that had super complicated, just had digestive issues, this type of thing, where they did respond to one round of treatment. That's not common right now.
I will also say I personally love breaks. Like I think breaks are
Breaks.
super useful
Yeah.
because you take, you
Yeah.
stop. What's still here?
Right.
Oh, whoa, we're not done yet. Okay, let's switch it up.
Mhm.
Or okay, we're done. I
Right.
love breaks.
Mhm.
Yeah.
Right. And there's also a trick I learned from one of my mentors. If you have a particular botanical that's working per se, or prescription, if we're going that route, and it stops working, you can take a break for 7 to 10 days. There's usually going to be some resistant species that are weaker genetically that will die off in that time. And then that same product can work again. So there's many different reasons to take a break.
Great.
Okay. That's all I have on botanicals.
That's a lot.
Do we want to go into
Yes.
dietary?
Yeah.
Yes.
Okay. So there's quite a bit of confusion on dietary changes that we think are necessary or helpful. And my overall approach has changed over the years. Our goal, I like to be clear that our goal is not to have someone have a restrictive diet indefinitely, but there are certain foods that are problematic for some people that we don't have tools to resolve. And so I try to, with initial testing, figure out if someone has a gluten sensitivity and get really good objective data, like a yes or no on that answer. I don't like people saying I avoid it most of the time. I eat it sometimes and I don't notice anything. That's just, we don't know if we're creating a cascade of inflammation that's going to prevent us from making progress. So that's one food I try to get an answer to through regular lab testing that we'll talk about in our celiac and non-celiac gluten sensitivity talk, and secondary testing. So that's gluten. Dairy is a common one. So if they don't know whether or not dairy is a problem, we'll do potentially an elimination challenge, sometimes IgG food testing, which we'll again talk about separately.
And the goal of this is just really to decrease inflammation. It's not necessarily yeast specific.
Correct. That part is to decrease inflammation, although there is research showing a potential cross-reactivity between candida antibodies and antibodies to gluten and the potential development of celiac disease or non-celiac gluten sensitivity. So it still decreases inflammation, but if they have a fungal overgrowth, they might be at increased risk of mounting an immune response to yeast as well. So the other part of the diet that I think is more confusing is what do we do with starches and sugars and yeast and fermented products? And so as far as starches go, I don't automatically have people reduce healthy starches like rice, sweet potato, et cetera, unless they tell me it's problematic.
So you're keeping in more complex fibers. White rice?
White rice is usually better tolerated, but if they can do brown rice, we leave that alone as well.
Right.
Some people do have to minimize those until we treat the overgrowth for more time. But if they don't notice particular problems with those foods, I don't automatically remove them.
Great.
I always remove sugars. So I'm talking about any sugar except whole fruit. We remove dried fruit. It's super concentrated and it usually has molds and yeast growing on it. We remove all added sugars. Patients always ask, what about honey, maple syrup? I don't know. There's 10 other ones. All of those are out while we're treating it. You can do whole fruit. You can do stevia. If you tolerate sugar alcohols without increased GI symptoms, you can use them, but I think a lot of our patients do have issues with that. Stevia and monk fruit are fine if they don't have issues.
And monk fruit usually has erythritol in it, which is an alcohol sugar.
You can get monk fruit on its own. So that's an option if they don't tolerate sugar alcohols but tolerate monk fruit.
And no fruit juice.
No fruit juice, concentrated sugar and moldy.
Yep.
So that's the sugar part. And that, I try to tell patients long term, we want to minimize sugars for your general health, but we should be able to get you to a point where you can tolerate desserts here and there, that type of thing, like a normal consumption, dark chocolate, etc., in minimal quantities. So you don't have to be overly restrictive, but it's just not good for overall health. The other part is, what do we do with fermented foods and yeast related foods? So these don't feed the fungal issue, but they could be cross-reactive. So the way I explain it is, some people who have an overgrowth develop a cross-sensitivity to molds and yeasts in food. And that's in things like vinegar, except for distilled vinegar, dried fruit, nutritional yeast, breads with yeast, fermented vegetables have yeast and molds. And so this is not a long-term issue for most people, but we do what we call a 5-day yeast mold elimination challenge, which is adapted from Dr. Sydney Baker's yeast information booklet from like 1980 as well, that we have on the website that we can link to. So you remove those foods for 5 days. We can include a more comprehensive list, but it's typically fermented foods, anything moldy like dried fruit, nutritional yeast, vinegar, all of these things. And then whichever of those you miss from your diet, eat a bunch, see how you feel for a couple of days. It has a significant impact for probably 50% of the people I do it with, to the extent that some people, it solves their digestive issues.
And when you reintroduce the food, are you just having them full on reintroduce it, or are you doing it in a systematic way?
I have them, they don't have to reintroduce all at once for the test, but whichever ones they want to eat, a lot of people, it's vinegar. I just have them eat like normal quantities for a couple of days and see how they react for up to 3 days. Those foods are also high histamines, so that could be another reason they're reacting, but they're also high in molds and yeasts.
Right.
If they react or they're not sure, we keep those out for the first few weeks of the treatment. And if they don't have a response at all, there's no need to remove those. You can still consume them. Mushrooms is sort of like another one in that category that if you want to be more comprehensive, you could include, but you don't need to, like I have patients that have removed all of these healthy foods from their diet and we add them back and they were not causing any problems. So this is not an automatic that you have to remove these foods.
And I assume alcohol and probably kombucha are just off the table.
Those are in there as well. I tell them, if you have to have a drink, get a distilled liquor with club soda, or I forget, whichever one doesn't have sugar, club soda, I think. But don't do wines or beers. Limit alcohol in general while we're doing the treatment.
And kombucha has yeast in it.
It does. And I know my dentist said she had patients that were drinking kombucha all day and had severe decay because it's acid plus sugar.
Right.
So I don't recommend regular consumption of kombucha.
At least large quantities.
At least large quantities.
16-ounce bottles every day.
Yeah,
probably.
Probably not a good thing.
Yeah.
Oh, so it's not good for your bank account, but that's not my business.
That's true. So generally we're removing foods that cause inflammation for that person. That could be gluten and or dairy. We're removing added sugars. Only fruit is allowed, whole fruits. And then we're doing this yeast mold elimination either before we start treatment, or for some people, they just find it easier to just remove them for the first few weeks of treatment. That's also an option, just so they don't have to do a separate challenge.
Okay.
After the treatment, for a couple weeks at least, or when we've had some progress, we can then, if they had to remove those yeast and fermented foods, we can add those back to check for tolerance. And often after sometimes one, sometimes several courses of treatment, they're not as hyperreactive to yeast and molds and foods, and they can eat those again. There are some people that have developed sort of a yeast mold allergy that needs to be treated separately so they can eat those foods. But we always want to reintroduce every couple months and just check for tolerance, because often that can be brought back into the diet.
Okay, wait, I'm just going to go big picture real quick.
Yeah.
So simultaneously, you're doing all the foundations, you're supplementing with nutrition, you're doing herbal or prescription antifungals, and you're doing this challenge?
The challenge, I'll give them the option. If I suspect an issue at the first visit, I might just, while we're ordering labs and such, just say, do the 5-day yeast mold elimination to give us some information. If they don't get to it, or I forgot, we can either do the challenge before we start the treatment for overgrowth, or they can just remove those foods for the first couple of weeks of treatment.
And when I'm treating SIBO, part of my treatment is like, if you want to kill the mafia, you invite them all to a wedding. Like you basically are feeding and feeding it. Like you want to feed.
Right.
That's not true with fungus.
That's not, because we know sugar suppresses the immune system. So I don't want them eating refined sugars. There's no reason to do sugars as part of the program. I think it would decrease the efficacy of the treatment. Starches may, we know, in part feed bacterial and fungal overgrowth, and I don't remove those. So maybe we are feeding it to some extent, but I never encourage them, and if anything, ask them to remove all added sugars.
Okay.
And I do think it's worth a shout out to check in with people about restrictive diets and if they're okay with that, prior to having this, because a lot of people, that is triggering, and that is not something we want to
that's true
contribute to.
And that's always a challenge, because we know added sugars are just not healthy for any of us to any significant extent. But we also want to be able to have some things.
Yeah.
I'm sure I eat, there's dried fruit in the granola, there's things in there, but you just don't want to be having them in excessive quantities.
Right.
Even if a patient has a history of restrictive eating and we don't want to be as aggressive with the dietary modifications, we can still treat them and back up and just say, okay, what seems reasonable for you?
Yep.
Decreasing overall sugar, great, let's try that.
I think preserving a good relationship with food in the context of this is important and doable.
I think so. And we all have people who come in on very restrictive diets that I don't encourage, even if they're having some symptoms. Sometimes I'll say, it's okay to have symptoms. Like, just, we don't want to remove anything else. We're going to work on treating the other causes. So questions about the dietary modification aspect?
That was, I feel like that was great. Yeah.
Okay, great. That is it for that part.
Okay, let's move on to the next part. What's the next part?
All right, what is the next part? Okay, so the next part is whether we want to consider motility agents or adjunct medications if we're sort of getting stuck and someone's having relapses and we want to prevent recurrence, sort of like we do with SIBO. And so again, I haven't found research for this, but I recommend some of the same tips we use for SIBO, such as spacing meals, avoiding late night eating, an overnight 12-hour fast if possible, and working on sort of the cephalic phase of digestion, like trying to eat in a calm manner, taking a few deep breaths before eating, and working on the parasympathetic response.
So when are you bringing this on board?
That's a good question. I probably forget to bring it on board in the beginning. I think I usually think about it if someone's not making progress.
Yeah.
But I feel like it probably should be in the preventive, but also treatment phase to at least start to get used to some of these things.
Yeah, that's a really good idea, especially the meal spacing. That's never going to hurt.
It's never going to hurt.
Support the small intestine. In terms of prokinetics, are you giving those what would be your deciding factors on when to bring that in?
I'm bringing those in if someone is having recurrence of symptoms that we have to kind of keep treating over and over, and we're trying to troubleshoot, is it a hypersensitivity, which we'll talk about that, or could there be a motility issue like with SIBO? I haven't found any research on using prokinetics in patients for fungal overgrowth prevention, but it makes sense if they're accumulating bacteria that they could be accumulating fungal issues as well.
And the symptoms are like persistent bloating, nausea. Would you do it in the context of diarrhea? If they have like bloating and diarrhea?
I've mostly used it if they have bloating or constipation, or if they're having recurrence of symptoms and we're not ready to explore the hypersensitivity potential.
Got it. I'm always confused on people who have this persistent bloating picture and diarrhea.
Right. Yes. That's
because I don't want to speed things up in part of the intestines, but I kind of do in the small intestine.
Yeah.
So that's hard.
Yeah, that might be another episode.
Yeah.
The other intervention medication wise, outside of considering motility agents that I've been using a lot more, is this whole category of MCAS meds and supplements and antihistamines. And so, my mentors were always focused on root cause. And for many years, I feel like I sort of ignored symptoms for a while and just was hoping things would improve as we treated the root causes. But I've learned, ideally, we're treating both. And there's definitely a role for prescriptions. Again, I think some of us have personal biases where we don't want to take a lot of things. And so I just assumed my patients didn't want to take a lot of things, but a lot of them are happy to take things if they help their symptoms and it helps them get through the day. So I've been much more aggressively treating for potential MCAS histamine issues. I've been using a lot of oral cromolyn, ketotifen if tolerated. It does cause drowsiness that precludes its use in some patients, and also just trials of over-the-counter antihistamines. I prefer
using just the H1 blockers or H1s, H2s together.
I'm trying one at a time to see if it has any symptom improvement. If it does, we'll keep it on board and we might layer in more. Some patients need a combination of a couple different ones, prescription or natural, depending on what their preference is or what's working. And Dr. Efren says it's like a lock and a key. We're trying to find the one that works for that person, for their symptoms.
And you're doing 24-hour twice a day?
For Allegra, I'm doing 24-hour once a day.
Okay.
For Claritin, I'm going up to 10 milligrams twice a day if once a day isn't helping.
Got it.
And it hasn't been causing drowsiness or anticholinergic effects for most people.
Right.
Or, yeah. So, and it's not really preventing use, but some people it just doesn't work for.
And quercetin?
Quercetin, I've been trying. I can't say I've had the best results with it. I've been going up to the 1 gram 2 or 3 times a day. And I'm not sure, maybe it's not the right lock and key for the people I've tried it with. Cromolyn, it didn't work for like the first 20 people I used it for. I almost stopped prescribing it. And then I had a patient that said, this was miraculous. I want to up the dose to what you told me is the max, which is 8 vials a day. So I've been prescribing a lot more cromolyn. For some people, it works better if they do it 20 to 30 minutes before meals, as opposed to the full dose in their water bottle for the day.
I've had people dose cromolyn before like trigger foods that they know they struggle with, but they kind of need to be eating because their diet's so restrictive, and that works great.
Like
That's
right
good.
before? Or like 15 minutes
No,
before?
yeah,
15 to 20 minutes
like
before?
15. I usually say 15 to 30 minutes before those meals, so because it's expensive. And people are able to kind of prolong it because they don't need it for a lot of like breakfast. If it's pretty bland, they're usually fine.
Right.
And I've gotten great efficacy with quercetin. Like I have been able to get people off of
quercetin or isoquercetin or both?
Just quercetin.
Just quercetin.
Yep.
Are you using a particular brand, Rebecca?
I don't know that I've committed to one.
So maybe it just depends on the patient.
Yeah. I'll go back and look and see if there's a particular brand.
I also would like to plug nettles. Like I feel like there are some patients where nettles is like, whoa, that's my hardcore drug, nettles.
Plain
and I was
nettles
like, freeze dried.
Freeze-dried nettles.
Yeah, encapsulated. Yep.
Yeah.
Is there a company you're using?
Eclectic has a really good one, but Gaia has a good nettle too.
Okay.
Do you ever give it as the DHIS like combination?
I use that with people. They've had good success, I feel like.
You just have to dose
I've used it with people too. I'm going to say hit or miss.
Okay.
Yeah.
Throwing some spaghetti against the wall, seeing if it sticks.
If they have a really like atopic picture, I'll just do every type of nettle you can possibly like.
This is my OD on nettle. Yeah.
Make a nettle tincture, anything they can do. And, people usually pick a couple they're okay with. But the DHIS seems to be pretty good.
I've had people have good success with that, especially if they don't tolerate, a patient with MCAS who doesn't tolerate any of the other meds and she tolerates DHIS.
Yeah.
Right. Amazing.
So, okay. So
then just one more plug, just when we're talking about SIFO and MCAS or SIBO and MCAS, you got to clear up the SIFO or the SIBO and then the MCAS can get better.
Right.
But you don't have to necessarily do what I used to do, which is just have the patient have symptoms until you get to an endpoint of treating the overgrowth.
And that is when suppression is palliative.
Yeah.
That palliative, just supporting them so they're not miserable.
And just to quickly, so the other prescriptions we use for the MCAS histamine type issues, famotidine once or twice a day is the hydroxyzine. Sometimes I've used cyproheptadine. I've occasionally used, which is an old one that also works for migraine prophylaxis. So there's a host of them. We'll do a separate episode on it. Vitamin C is also a common natural one that we use with quercetin. So I think that's everything for sort of adjunct medications that we think about with potentially prokinetics, motility agents, and mast cell stabilizing medications and supplements. We'll talk more about probiotics and some of the research on that.
You want to do a sum up?
I'd love to.
Okay.
So tons of information in this one. This is our part 3 of SIFO.
Part 3 of 100.
Part 3 of 100, it's seeming to be. So my takeaway of this section was there's a lot of individual treatment options, and we really do have to focus on what else is going on with the patient, comorbidities. Diet-wise are very unique and individualized, so allow them to kind of suss out for themselves what works and what doesn't work, with the goal of expanding their diet as much as we possibly can as soon as possible for them. And it's not necessary to keep them on a totally carb-free diet while doing SIFO treatment.
And then my takeaway was like what we did with the hypersensitivities at the end, which is sometimes with hypersensitivities like mast cell, we're thinking about these other comorbidities that are worsening the presentation of the mast cell issues.
Totally.
Great, Ami. This was awesome.
This was brilliant.
This was awesome. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
It's If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.